indicators as we go along. I'll end by sharing my thoughts on what I believe the role of county leadership is in fostering the successful integration at the county. And this specifically, in reference here is Nairobi and Kajiado. The next slide, please. Now, allow me to start by referencing some of the literature that we have on integration of HIV services. The first paper that you see there is by Sokoina and colleagues. It's an Inter-Africa study, which was an integrated management study for HIV, diabetes, and hypertension care, a pragmatic cluster-controlled trial that randomly allocated primary healthcare facilities in Uganda and Tanzania to provide either integrated care or standard care for the three conditions: HIV, diabetes, and hypertension. Now, the main outcome from this study was that integration achieved outcomes that were non-inferior to standard care. The second one, the one at the center there, is from South Africa, and it refers to the Integrated Chronic Disease Model, ICDM, which is a public health approach that consisted of 4 components. There's facility reorganization, there was a clinical supportive management, assisted self-support management for clients, and strengthening of support systems and structures outside the facilities. So in ICDM, they sought to achieve optimal clinical outcomes for patients with chronic communicable and NCDs as an innovation responding to the growing burden of disease in an efficient and cost-effective manner. So ICDM was implemented across 42 primary healthcare clinics in South Africa. And to assess sustainability, they used a survey, a tool called the National Health Service Institute for Innovation Improvement Sustainability Model Assessment Tool, which showed that there was less than optimal involvement of clinical leadership, and that's specifically doctors, negative staff behavior towards ICDM, and adaptability. And that in itself had the limitation and limited the potential of scale up and sustainability of this model. Now, the third part is a paper again by colleagues from Bill and Melinda Gates, a paper by Erin Kranz, who introduces the concept of differentiated service delivery 2.0. Now, they argue that DSD 1.0 sought to simplify care for stable PLHIV. Remember, we classified clients as being stable or unstable, and therefore put them on a particular pathway. And the primary aim of this was really to ease the burden on healthcare workers. But now we need to move further to DSD 2.0, and this aims to provide holistic care to people living with HIV by having an expanded focus, which includes integration of non-HIV services into HIV programs, and specifically into DSD models. Next slide. And so we ask ourselves then, what would we consider to be the core characteristics of integrated, people-centered health services? Next slide. So here is an infographic, and it's derived from WHO. It's based on one of the recent technical briefs WHO provided. WHO considers integrated health services as management and delivery of health services so that people receive a continuum of health promotion, disease prevention, diagnosis, treatment, management, rehabilitation, and palliative care through the different functions, activities, and sites within the health system. That's quite a mouthful. So the core characteristics are what I show here on the slide. And just to mention but a few, you'll see that in the focus here, we have sustainability, we have equity, services should be coordinated, they should be co-produced, they should be empowering, they should be comprehensive, etc., etc. I just want you to take note on the focus on sustainability, which is really considered a central characteristic. Next slide. But let's make this a little bit simpler. So I want to make this the crux of this, or the thrust of this presentation. We can consider two kinds of integration, and that's service integration and systems integration. So service integration, we look at HIV services being aligned for where services are delivered. For example, the facility and the community, and that could include non-governmental organizations or even local CSOs, and what is delivered in the same setting and point of time to meet population and person-centered specific needs. So you could think of service integration in two dimensions. One, horizontally, where you're now providing care for two things and delivering them at the same encounter, or vertical. And in vertical integration, it's really a seamless transition of care from your lower level facilities to secondary and tertiary care. So moving between your care 2 all the way to 6 levels within the healthcare delivery system. Now, on the other hand, when you think about systems integration, we have parallel HIV systems. And you're going to integrate these HIV systems, workforce within broader country-led health systems that enable provision of services to meet population and person-centered specific needs. So, broadly, workforce, supply chain, health financing, all these are included there. And so those constitute what you'd consider the systems integration piece. Next slide. And so USAID has also pronounced itself, on this by providing priorities that we will be focusing on for a sustainable global HIV response. And as you can see, leading the pack again, we have integration, just to underscore its central importance to our strategy. So the others are, for example, addressing inequities. We have the agenda of localization, having a client-centered supply chain, a resilient workforce, and optimizing health financing. Next slide. And here in Kenya, we are currently working on our sustainability roadmap. In fact, as we speak, we are currently, at a meeting for, which ends today. One of the many meetings where we will be determining a roadmap for this country. And we expect to have a deliverable to be shared on World AIDS Day in December 1 of 2024. So on this slide, you see the current constitution of the team that is led at the PS level by a steering committee that's co-chaired by both NASCOP and NSDCC. So there's 5 thematic work streams. There's one discussing service delivery. Another is discussing health financing. A third one is looking at governance aspects and leadership. Another one is looking at health products and technologies, so the commodities, and also the legal frameworks within which will fit this sustainability conversation. Membership is drawn from, national, county, CSOs, other multilateral, other players to develop this plan. So we are also in sync as a country. Next slide. So then how do we measure integration? And here, really, this is getting to the crux of what we'll discuss today. Several thoughts come to mind, and I'll ask that we move to the next slide. One of the classic ways to do or to measure integration patient experiences, and typically we consider some indicators such as the balancing indicators when you look at CQI models, such as wait time. Now on this slide, Dio and colleagues modeled the impact of integrating HIV and OPD services on patient waiting times in an urban clinic in Zambia. What they found out was that increased wait times of up to 36% occurred after integration. So that's expected. However, once they controlled for operational conditions, so for example, as availability of staff and the long breaks between clients that staff were taking, integration was found to have the potential to reduce wait times because of more efficient use of resources. Next slide. Another way which we can also measure integration is using capability maturity models. And this is a common strategy that the Sequin Learning Network utilizes. So at USAID, we recently had a stock take for, and you may have collected this data, where we had, one of the variables when we are looking at integration, looking at what was your thought around the integration model that you're implementing. Was it fully mature? Was it nascent? Was it partial? Midway. And so under this approach, for each of the different integration models that you conduct, one would identify key domains of what you consider a functional system, the stages of maturity, and those appear color-coded for each domain, and then complete a self-assessment at different times. So that's at baseline, annually, and at the end line. So on the left of the slide, or rather on the right of the slide, you can see the stepwise assessment, and that can be summarized in a table. So with the stage 5 being the most mature and stage 1 being the least mature. Next slide. So the PHC theory of change also provides another approach to look at how we could measure integration. Now, there are 3 main approaches when you think theory of change. That's integrated that appears on your left. You have integrated health services with an emphasis on PHC. You also would like to have empowered people and community that are central in this conversation. And it also involves a multi-sectoral policy and action. So going beyond the health piece, because there are other intervening or sectors that, play into health. At the center there, we are reliant on 14 levers, which can be considered as being either operational or strategic. So the strategic ones appear at the top, where you're thinking about political commitment, governance, funding, and the engagement of communities. So this will deliver 3 key results that appear now towards the third set of boxes there. And the 3 key results are improved access, utilization, and quality of services. You also want to have improved participation and increased health literacy and care seeking by the masses. And lastly, you also want to have improved determinants of health, all leading to improved or achieved sustainable development goals. And here, teams would sit and determine which elements and select which elements within this theory of change that they would be keen to monitor, and then from there, pick out applicable indicators. Next slide. But perhaps one of the frameworks that I'm more inclined towards is the USAID's measurement for action framework. And this is a logical, results-based framework that builds upon previous PHC measurement work that includes the PHC Performance Initiative that was done between 2015 and 2022, as well as the WHO and UNICEF PHC monitoring framework and indicators, the PHC MFI, monitoring health systems through a primary healthcare lens to articulate the various components of a PHC-oriented health system and the outcomes and impact that can result from this approach. The measurement for action framework builds upon the PHC monitoring framework and indicators, but with a focus at the SNU level or the county level, in our case in Kenya. So I'd like you to take note on how the measurement for action framework is organized, with structures on your left, inputs following, and then the processes, outputs and outcomes, and impacts. At the base are three foundational aspects where we need to have integration, equity, and the community as our guiding principles. Structures really refer to the governing policies, the frameworks and management and financial structures in place to define, monitor, finance, and deliver PHC in a country. Inputs would be your facilities, the healthcare professionals, supplies, and funds needed to deliver services, high quality PHC services. The processes would be how you operationalize the functionality of PHC. And in here you have, for example, the models of PHC delivery, community engagement and partnerships, integration and interoperability of systems, and resilient health systems and services. Your outputs are near-term results and health systems improvements. So for example, service success, availability, quality, etc. Outcomes come as a result of changes in effective coverage across essential services. So you have financial protection as well, and health security, which occur over time as a result of these efforts to strengthen the health system. And then impact is distal, it's longer term. The impacts which we expect from strengthening PHC approach. And so here you look at, do we have equitable and resilient health systems? Do we have improved health and decreased mortality, etc., etc.? Next slide. And so here on this table, on this slide and the next slide, a table of indicators. It spills into two slides. So here I show a list of indicators that we could prioritize. There are three measurement groups. So, PHC foundations, PHCF, you'll see that. Measuring for impact, which are early on, maybe less than 2 years. And then monitoring for change, which you will be monitoring every 6 to 12 months. So these indicators, as you look at them, they appear a little small, but you can look further into this. They map to the PHC MFI and other sources such as the Performance Monitoring for Action and the DHS, the Demographic and Health Surveys, and multiple indicator cluster surveys, and the UN Interagency Group for Child Mortality Estimation. So you will see there, for instance, in the input section, you have example of indicators such as, do facilities meet core physical infrastructure requirements? What are your health worker vacancy rates? Do you have essential medicines, availability of priority equipment, and so on? When you look at processes, you're looking at whether you have formal community healthcare worker programs in Kenya, that would be community health promoters, whether we also have outreach or carry, that's part of what we consider as our PHC strategy. Existence of facility budgets, so you're thinking about the expenditures, also provider availability, and whether we have performance measurement for quality improvement. So CQI is also critical there. Next slide. And the outputs, again, these are the aspects of accessibility, affordability, and accessibility. So you're looking again, do you have geographical access to the services? What are the patient-reported experiences at first contact? You're looking at patient-reported experiences, service continuity, looking at comprehensiveness, whether the referral loops are coordinated and completed. Again, you can also look at whether facilities have mechanisms for patient complaints and feedback. So a lot of that is around the patient experiences. And also a composite, you can have a composite indicator for integrated service delivery. And when we talk about outcomes, then you're talking about the health service coverage index. And impact, again, would be the all-cause mortality rates among women, and also among children, and so on and so forth. Next slide. And so if you really want to succeed, you need to know or measure or have a priori, an indication of what success looks like. And so yeah, I pause and ask, what does successful integration look like? And so, going back to what my brief was to offer insights on considerations for counties in fostering successful integration. So using the two integration definitions that we wanted to look at, systems and service integration. When you think about service integration, having effective models of PHC delivery is critical. What does that look like? Community engagement and partnerships. How do we strive that? What do we measure and consider to be success in that realm? And then again, what's this subnational, the county and facility management looking like? So these are the three domains that I would consider and set metrics to consider what success, so even set and paint a picture of what success would look like, at least on the service level. On the systems side, we look at integration between systems and interoperability. How is your ICHIS, integrating into the EMR? So we have Taifa EMR, we have the Kenya EMR, and so on. And then do you have resilient health systems and services being provided? So, multi-sectoral platforms, and at the county level, are you meeting regularly to address cross-sectoral issues? Do you have strengthened coordination even within GAOs, at county departments of health, and other? Have you also mainstreamed your surveillance by CHPs, and so on and so forth? So this would be the parameters that you'd have to have in mind when you want to measure what successful integration would look like. Next slide. And so moving from that abstract picture to where would you start as a county? What are the considerations that you put in place? And on this table, on this slide rather, I've provided one memo that I borrowed from a county, that's Embu County, who took the bold step to ensure that all staff were able to be fluent in all service provision by being, by rotating through all departments. And that was a memo that they wrote to direct our healthcare workers to take on integration, to enable integration to start. So several considerations. Now, you want to look at focus areas of policy, leadership, and coordination, very critical. Do we have the right guidelines? Do we have the capacity to support integration within the county? What are the coordination and accountability mechanisms? When you think about service delivery, how equipped are our health facilities with the adequate infrastructure or equipment to deliver integrated services? Our HRH equipped with adequate knowledge and skills, and you can be able to map out what the capacity gaps are through processes even such as WISN. There is community empowerment and partnerships and systems strengthening between community and facility to ensure that we enhance referral for integrated services. Also using community strategic information just to ensure accountability. We cannot forget the important role that resource mobilization and partnerships play. And we have to look at the funding mechanisms and payment modalities and how we scale this up. And of course, monitoring and evaluation has to be at the base and core of all these efforts. Next slide. And thinking around what are the considerations or really the challenges towards successful integration? We have to be alive to all this. There are many challenges, but suffice it to say that we could consider 5 broad categories. Yeah, the elephant in the room is always health workforce, and you want to look at the technical capacity of healthcare workers. Do you have sufficient numbers trained? Have you done your workload indicator staffing for staffing needs? Are staff motivated? What's their attitude and biases? Remember in one of those papers, the ICDM one, that attitudes of staff really hindered integration efforts. The supply chain and logistics would be another big bucket to consider. And there may be resistance, and will be a lot of resistance from systems that have strong procurement systems. So think loading over other products onto the HIV supply chain, which is over time becomes specialized and very resilient. There is increased logistics complexity. When you have integrated supply chain management, how do you deal with that to prevent commodity stockouts? So that becomes really a sticking point. A third one would be the health informatics and monitoring evaluation. We have to be very careful to ensure that we don't encumber our healthcare workers with increased burden to collect and report additional indicators. As we know, there are no standard indicators for integration, and people will have to select their own indicators at this point. We also need to look at how well our tools are adapted to measure or even to capture integrated service provision. And also there's a need to ensure that our monitoring systems are interlinked and that data quality is top-notch. Another challenge would be infrastructure. This is common, and we always are talking about limited physical space at service delivery points, and this will come to bear as we embark on this journey. And finally, service delivery. There will be increased need for support supervision just to ensure quality, and that we don't speak against each other. We need to speak in harmony and do not confuse the healthcare workers. So we need to also establish functional referral systems, as well as update service delivery guidelines and norms. So next slide, this is my penultimate slide. There are several opportunities to catalyze integration efforts. And the big one, and everybody's talking about it right now, is the political will and our ability to seize the opportunity for policy change. How are we aligning with BITA, the UHC, SHA, and SHE? You know, it's a talk of town since October 1, we've been rolling this out. We could also look at market-based approaches. Where's the private sector in this? Private sector engagement framework exists. How are we utilizing this? How are counties thinking around this? We have clients who are willing to pay. We also have to think about expanded access programs. How do we utilize communities to have better access programs and the intersection with that? Communities have to participate in all that we do. You know the MIPA principles, nothing for us without us and nothing for our clients without their engagement. And we also have to have, community-led monitoring as part of quality assurance. At the systems level, we need to think about, joint forecasting and quantification processes and integrating end-to-end solutions. That's for supply chain, health management information systems, health financing. And finally, innovation has to be what we live and breathe. Innovation has to be useful and transformational. We have to always have this learning agenda. We have to learn from each other, continuously adapting, and that really refers to the south-to-south learning. So I will end on the next slide and just say, provide a recap and say that in all that we do, integration has to remain patient-centered in its outlook. If we move away from the patient, we will not be achieving the goals of what we set out to do. Integration also has to be contextual. It looks different in different settings, and therefore, as everybody says, there's no one size that fits all situations. So we have to bear that in mind. And measuring integration is paramount. Remember that patients will always vote with their feet. You will know your quality of services based on what patients' experience is. And lastly, integration is not a panacea, but it remains a critical pathway to attaining sustainability. So with that, I want to thank you and, turn it back to the moderator. Thank you very much.
Thank you very much, Daktari, for that insightful and very interesting discussion. I know some few months ago we ended as conference in Mombasa just to discuss on the integration of the services as we move forward. So I want to invite reactions, questions, comments to what we have just concluded. So anyone with a comment, you can put in the chat. Meanwhile, I want to ask Samson to recognize the leadership of Faria Jamii. I've seen Dr. Rondi, Dr. Ison, and also I'm told we have team from USID. So Sam, maybe can take over as we wait for the questions to stream in or comments.
All right. Thank you, Chris, and good morning, everyone. Thank you, Dr. Dunstan, for this very insightful presentation. It's very timely. This is the time that we are trying to find our way in regard now to setting our foot right into the integration agenda. So I would really want to invite Dr. Rezon, is in the call, to say hi. Then she can be able to also invite other people that she may want to also make their remarks on this. Dr. Rezon, thank you.
So good morning, everybody, and happy Thursday and happy new FY25. Thank you so much, Chris, and the rest of the TWG team for allowing us to have this session. And thank you, Dunstan, for being available for the very first TWG session to just set the framing. It sort of happened by default, but it's a good framing as we start the new financial year to really think about integration. I think it's really been a very valuable presentation with also practical ways to begin to take this integration journey forward, and really just appreciating what you've shared and giving us ways that we can move forward towards actually, implementing the programs in an integrated way, measuring them and leveraging the different touch points from health system strengthening and service delivery that would get us there. So just thank you very much to everybody. Back to you, Samson.
Right. Thank you very much, Dr. Rezon, for those insights. So I think, Chris, I would want to invite you to take the meeting back to you so that you can also bring on board anyone maybe from the county whom you'd want to also make any remarks. Over to you, Chris.
Yeah, thank you. Thank you, Sam. So there's a comment from Janet before I invite team from the county. So thank you for presentation. MDT approach is very valuable to achieve integration of HIV services to non-HIV services. So that's a very important point from Janet. Before I continue, because I'm told also to mention on the upcoming conference, I want to invite Alice. I've seen Alice is on the call to say a word as I share my screen, because I want to just say something small on the upcoming scientific conference for the Nairobi County. So Alice.
Hello, and can you hear me?
Yes, Alice.
Oh, thank you very much. Good morning to us. I want to take this opportunity to thank Dunstan for the very elaborate presentation, basically looking at integration and the various considerations we may need to make to ensure effective consideration, putting the patient at the center of our discussions. Thank you, Dr. Rezon, for your remarks, and Chris for hosting us, and of course having a very important topic as we roll into the new financial year. So this buzz has already kicked off. I would want to say that the HIV program is very mature, and some of these presentations or some of the examples that have been given here are things that are already happening, only that they were not elaborate and not well defined, and people didn't know exactly what it is that we're doing. Because if you look at MCH integration or HIV integration, it has been there. If you look at TB HIV, it has been there, but not well defined. So I guess now this call is a clarion call for all of us to ensure we are very deliberate in terms of how we are rolling out integration and ensuring that quality remains the center of our integration models. As has been said, it is not a one-size-fits-all. So what is that integration model that works for you? And I think that's what we are looking towards doing. And I'm telling guys to document, just document your processes. Anything you start, please make sure you indicate so that we know where you started. And as you progress where you are headed to, at least have like a roadmap to show exactly what it is that you want to do, so that we don't lose out on the gains that we have made over years. And if possible, ensure monitoring across the whole cascade, so that where we drop or where we seem not to be doing well, we shall be quick to be able to go back and review so that we do not lose out. And again, as has been emphasized, the need to put the client at the center. As we are doing this integration, can we also make sure that we have a meaningful engagement of the networks of people living with HIV, so that the decision is not already for the healthcare workers, but a decision that needs to involve the clients that we are serving, so that they're agreeable and they are able to give us meaningful feedback, even as we look into community-led monitoring. Before that is done, are we able to come up with county-owned solutions that are maybe very specific to sites, so clients can give you a feedback and you're able to, improve on the areas that seem not to be working very well. Otherwise, thank you very much. I'm only hoping with every person wherever you are, and especially so for the mentors, the sub-county AIDS and STI coordinators, we wish to make this part and parcel of our routine work. Wherever you go, let us discuss the integration in every facility and ensuring that every facility understands their role. Let us know what the gaps are so that we can also plan around the gaps that are there to make it better. I know for Kajiado, we have a roadmap that is already drawn. We shall be having a discussion around that roadmap just to affirm what we've been doing and ensure that we are documenting every step of the way. So we are welcome to ideas as we visit your sites, or even as we discuss with you virtually. We shall be welcome to ideas. And of course, we are very open so that we can work with what each facility feels is best or works best for them, as long as the client is our main focus. So I want to wish as well, even as we continue to deliberate, and thank you very much for having us. Have a pleasant day, everyone. I'm not closing the meeting. I'm handing it over back to Chris. Thank you very much, Chris, and over to you.
Thank you, Alice, for those insightful remarks. So I want to just go through the chat box before I go to discuss the upcoming conference. So we have a comment from Joseph Sankok: digitization of services and sustained HRH support is paramount to successful integration journey. As counties, we are anxious to have this strengthened, and partnering with USAID is now needed more than ever. So that's a comment from Joseph Sankok. Then we have Peter Molo. He's addressing Dr. Dunstan. Considering that most of the healthcare workforce are project-based, how would we ensure that these healthcare workers are transitioned to their respective counties? Maybe Dunstan, you can respond to that.
Thank you, Chris, for that question. I think that I'm just looking. That's from Peter. Yeah. So yes. So this is a lot of the healthcare workers who have been supported through programs. There have been plans and conversations with counties just to have, an onboarding to the county health and public health systems or the county systems. It is our hope that there are several strategies. We've been doing workload indicator staffing needs just to ensure that we right size. It's not a simple solution, it's multi-pronged, and it has to be a county by county conversation where a lot of advocacy is conducted, with counties also bringing to bear or to bringing to the table what they're able to support. There have been transition plans, and those can be looked at gradually, where every year there are conversations between the partner and the county on how much can be absorbed. It is not something that we can cure overnight, but it requires continued advocacy and also creative ways of using the existing HRH to do more with less. So yeah, that would be my response for now. But it's a long conversation that centers around how much we bring to the table, resource allocation, and having a transition plan, which again will also form part of the sustainability conversation that we are engaging in. Thank you.
Yeah, thank you, Dunstan. Before I go to the next comment, I've seen Dr. Reson's is up. Doc.
Yeah, thanks again, Chris. I was just going to reiterate, but Dunstan mentioned it, so I'd actually put my hand down. This HRH conversation is a big part of the sustainability discussion that Dunstan mentioned is ongoing now. To just, again, provide practical ways for counties to take this up as an operational plan. So it is something that will a method to having that transition really effected. So it's an ongoing conversation, and we'll take all of us thinking together to see how we can really optimize the workforce we have and really reorient the workforce towards an integrated service delivery model, and working out ways together on how to build operational efficiencies with who we have on the table to really provide these integrated services. And again, it's not going to be one answer for everyone. It will look different at different facilities, different sizes of facilities, and then even different counties and sub-counties. So I don't see Director Lydia here, but as she always reminds us, this integration is a journey. So even as we embark on it together, we may not have all the answers together at the beginning, but together we will find them as we go along. So just that's all I wanted to add, Chris, to that discussion.
Yeah, thank you, Doc. Before I go to other comment, let me just go through this poster for the first health scientific conference for Nairobi City County, and then we can address the 2-3 comments on the chat. So we have been informed by my bosses just to mention on the planned scientific conference, and of course the call for abstracts. So the theme for this year, or for our first conference, is advancing health equity towards resilient, sustainable, people-centered primary health care systems in Nairobi. You can see everyone is talking about sustainability as we move towards the primary healthcare systems. So we are having the website that has been created just for the purpose of this health conference, and I've shared the link in the chat box. I can reshare again, but this is how basically the conference looks like. Sorry about that. Sorry about that. Let me just share again. Someone was sharing, okay. Yeah, so basically we are asked to submit our abstract based on different the thematic areas that have been mentioned. Give me 1 minute to just share that. 1 minute. I think it's here. Yeah, so let me share again. So this is how the website looks like. Just a quick one. I know you're almost at the top of the hour. So this is how the website looks like. So if you click on that, the link that I shared, you will be able to see this, and you're able to submit your abstract for different sub-themes in the website. So, and there's a guideline on how to submit abstract. And of course, we have different, how to pay the corporate package, all of that. You can be able to get these from our website. So Doc, your ad is up again.
No, and I think you can finish. I've just realized there are quite a number of other USAID colleagues on board. We can give them a chance at the end to acknowledge them, but just go ahead and finish. Okay. Thank you, Doc.
So this is how the website looks like. I want to reshare the link again so that you can interact with it in case of any challenges. We are here to support. So let me just go through the chat very quickly, chat box very quickly. So there was a comment from Peter again. Those who will be moving from CCC to general OPD, are there plans to capacity build them as well? Some have been in CCC for more than 10 years and may need to be retrained to be effective in their department. I think that one, the team that is, of course, working on transitioning and the integration, something that they need to put in mind. So that's what a comment from Joab. A great presentation. What are some of the threats to the attainment of sustainable integration and any possible remedies? So maybe that question is again directed to Dunstan. Then lastly, some of the threats include commodity security within the PCN and primary healthcare, ineffective patient referral networks, and healthcare staffing ratios versus facility workload. Of course, that has always been a problem, has been a challenge. And then there is a comment lastly from Darius Nyamai. So is it possible to strengthen the capacity of primary healthcare on practice-based research? It is important to be part evidence generation rather than just receiving the guideline for implementation. Yeah, I like that point. So that we are able to implement what has more of evidence-based, something that are shown to work. So I want to stop sharing this. Then I invite Dr. Rezon to recognize the leadership of USAID. Dr. Dunstan, you have something to share before I invite Dr. Rezon?
Yeah, just a quick, quick response to some of those queries. I think very good observations. And as we've probably pointed out during the, as a running thread, attitude is always a big threat. If you have poor attitude towards the integration, if you think it won't work, it won't work. But if you embrace it and take it on, that you are able to surmount that. People using systems, commodity stockouts, those could be threats for attaining integration. But then again on the comment on the, those retraining, of course, there will be refreshers and on-job trainings, which will be probably planned by counties based on staff needs. And I like the last point about research. Even part of the, integration conversation where we had a conference in Mombasa, I think that was just showcasing what's already working in Kenya. And, learning from each other, borrowing from each other, we can always, improve on what we have and document what we have contextually, as well as conduct implementation research. So those would be my quick comments around this. Thanks.
Thank
Back
you.
to you.
Thank you, Doc. Thank you, Doc. So I want to welcome Dr. Rezon.
Great, thank you very much. I see Dr. Sally Okutoi, if she's here, and I also saw Carol Nzivo. Maybe they can just come off mute and say hello. These are colleagues who support us from USAID, and anyone else who I may not see. Carol, Sally, go ahead.
Thanks, Dr. Rezon. Can you hear me?
Yes, we can.
Okay. Good morning, colleagues. Thanks so much for a very good session. I think this is what we are living and breathing now, ensuring that we have integration of HIV into primary health care, into the larger health systems, and also for the bigger sustainability agenda. So we are very happy to be here and also to support the process and learn and work with you in any way. Thank you very much for the great session, Dr. Dunstan Achoka, and even the organizers. Back to you, Rezon.
Great, thank you. And others had joined. So thank you very much to all our USAID counterparts for joining and providing us with this guidance really at the start of the year. It's a very, very good framing presentation. So I think, Chris, back to you for any closing, and I think we're done from our side. Thank you.
Thank you, Doc, and thank you, team, for we've had a very insightful discussion. Very important to start the year with such mind-stimulating discussion, considering where we are heading to as a HIV program. And I think it has come at the right time. So we are 3 minutes past time. So I want to really thank everyone. Thank Dr. Dunstan for taking time to be with us today. The USAID Faria Jamii team for organizing and making sure that we have the poster to disseminate the invitation for this meeting. So from my side and from the Secretariat, I wish to call it a meeting, and we can leave at our own pleasure. Thank you all, and bye-bye.
Thank you.
Thank you. Bye.